see, mine's a 2013. I haven't received my 2014 yet. I have the 2013, so hopefully my book will be in this week. Does everyone have the professional version of this coding manual? What's that? Well, this should be what's at the bookstore. But some people tend to order from different sources, so I just want to make sure. There is a difference. This professional version actually has a lot of illustrations. It's got a lot of information in it, which is not present in just the standard CPT manual. So when I refer to the CPT manual, this is what I'm referring to. This is what they consider the coding manual for the CPT.
They have also in the bookstore the availability of just an online, they give you a code and you access it on a computer. Is that something you recommend, or do you have a thought either way?
When you take the coding test, you have to bring a manual. You don't have access to computer software, applications, programs. So it's good to become familiar with the manual process of looking up and assigning the codes. So definitely. Plus you can bring your book to the test with you when you take your certifications. You can take it along with you. So you also have your workbook and you have your textbook. Has anybody noticed that all the answers are available in both of them? Although the answers are there, what I'd like everyone to do is still work through the exercises, review the answers, and then determine what the rationale is. There's some gray for those of you who have had ICD coding. When I talk about aspects of gray, ICD has a little gray because a lot of information in that classification system is not elsewhere classified, not otherwise specified. There's a lot of gray, let's say. In CPT coding, one of the main things that you have to take into consideration is matching up your terms the best that you can with the definitions that you're provided with. So you're going to match up the best that you can. You don't want to, what they call upcode, and does anyone know what upcode is? Robert?
Well, it's kind of a type of fraud to give a more
no, you're right there. You're right there.
To give a more of a detailed code when actually something else was done.
Right. So in other words, what upcoding is actually specifying that more was done during the specific procedure than what was actually done. They also have undercoding. What happens if you undercode? You're not going to get charged with fraud, right? Although they do monitor that. Because if you're continually undercoding, it's kind of like waving a big red flag.
And you're not getting paid as much as for being a provider.
Absolutely.
But if you're doing upcoding, you're getting paid too much for that service, so that's fraudulent, right? Is that what you mean?
Absolutely. Yeah. So both raise red flags. Upcoding is actually, you're really committing fraud because you're stealing. You know, when you have undercoding, you're not providing the service to the healthcare organization or the provider that you should be. You're not coding appropriately. So that's also waving a big red flag. CPT, which is the current procedural terminology classification system, is based on what they call RVRVS, which is a resource-based, resource-based relative value set or system. Does anyone know what a DRG is? A DRG is a diagnosis-related group. So the difference between ICD, which ICD is our diagnosis coding, when ICD codes are assigned to a particular illness or disease, they get classified into DRGs. DRGs drive the reimbursement. If you have a patient that has specific comorbidities which means they have more than one specific type of illness, that drives up the reimbursement to the facility, because the facility is not only providing care for diagnoses 1, the primary, they're also providing care for the secondary and more, whatever type of diagnoses are applied to that particular patient. When you have the CPT, it's the resource-based. So when the American Medical Association developed CPT back in 1966, when they developed this, they took into consideration all of the services, procedures, everything that is performed by a healthcare provider, outpatient service, ambulatory services. They took into consideration what cost is required, what resources are required. And they determined a fee schedule based on the resources utilized. If you have a patient that comes in that requires a tonsillectomy, okay? If a patient that comes in, they need a tonsillectomy performed. You have a patient that comes in that needs a splint attached. What service is going to get a little bit more money? Doesn't take a rocket scientist, right? But what they've done is they've actually determined, based on historical data, surveys, they've taken and they've factored in everything that needs to be factored in to drive the reimbursement for procedures and services that are performed out there. Make sense? So when you have in ICD, they have, it's called the CMS 1500 form. That's the claims form that's used for inpatient services. Everyone here, do you realize that ICD is used for inpatient? Think of that, the I, inpatient, I. So ICD is used for that. ICD Volume 3 is procedure codes, soon to be the ICD-10 CMPCS. The CMPCS, which is the procedural coding system, replaces Volume 3 in ICD. It does not replace CPT. So although you have this new classification system with ICD, if it's an inpatient service, you're still using ICD codes. If it's an outpatient service, an ambulatory service, if it's a allied health professional service, a consultation, a psychiatrist, home health, CPT. Okay? Everybody get that? Okay. Can anyone tell me who developed ICD? I gave it away. Who? Absolutely. Yes. Absolutely. The World Health Organization developed ICD. ICD-CM is actually the clinical modification, which is the United States version of ICD. Yeah. The CM. That stands for clinical modification. So again, CPT was developed by the AMA in 1966. CMS adapted the CPT system. I gotta be honest with you, I gotta be frank with you. AMA and CPT, does anyone know historically the relationship between the two as far as button heads? It goes back to the 1800s. I'll share a timeline. It goes back to the 1800s. It's actually kind of not comical, because you know, you get a lot of gridlock when that tends to occur. So in this whole process, they are still, with ICD-10, there's still a lot of gridlock taking place. The CPT was developed because originally, when ICD was developed and first started in 1979, it was used here in the United States. It didn't address any type of durable medical equipment. It didn't address certain or specific procedures, injectable medicines. It didn't contain a lot of those services that are performed out there. You couldn't get the codes. So, of course, the AMA ended up developing the CPT coding manual, and then you have the CMS version, HCPT codes. HCPT codes are Volume 1 CPT. They're here. It's not a totally different coding classification. They have what they consider the national codes, which is the Volume 2, and they have the Volume 1, which is CPT. The national codes for HCPT are similar to, say, E-codes, environmental codes in ICD. They don't necessarily have to be reported by healthcare organizations. And when I've worked at hospitals, I've never used the Volume 2 or even the Volume, or they used to have a Volume 3 on the HCPCs, but I never used those. It wasn't required. More and more healthcare organizations are now eligible for certain incentives based on quality measures. Does anyone know anything about quality measures that are out there? They're kind of set out there by Medicare, and it's actually up to the facility as to whether or not they want to participate. If they participate, they're eligible for incentives. They receive monetary incentives for providing extra information to the US government. Not every provider gets involved with doing this, but it is a way to get supplementary income when you have so many different programs sunsetting and no longer being available to healthcare organizations. You know, it's kind of like, geez, if we monitor how many patients that we can assist in smoking cessation throughout the year, we could be eligible to X amount of dollars. That's easy enough, you know. So the national codes are essentially quality-based in the HCPT. Those codes are available through the Medicare website. There is a link on Blackboard in the coding resources. I did put a link to those HCPT codes. Other HCPT codes cover durable medical equipment. One thing about a HCPT code that's a little bit different about a CPT code. So right now we're in ICD clinical modification 9, right? Everyone knows that turns been delayed another year? Okay. So when we look at a ICD code, we're looking at a code 3 digits, decimal point, and up to 2, correct? Okay. When we look at a CPT code, CPT is broken down into 3 different volumes itself, volume 1, 2, and 3. So with CPT, a standard CPT code is 5 digits. Volume 2 CPT is what they call emerging. They're emerging. Actually, these are codes that haven't yet quite been approved for use. They have the same, almost the same setup, but they end in a F. Then we have the volume 3, which end in T. These are our technology codes. The T, technology, it's a good way to remember that one. So they're all 5 digits, except those final 2. You have the F and the T for volume 1 and volume 2, or volume 2 and volume 3. HCPT codes start with either an A, or a J, or an S. They start with the alphabetical. So depending on what it is, you have certification exam, because it will be on there. Typically, it's a J code. J code are our medicinal codes in HCPT. But if you see a code that is 5 digits, that starts with an alphabetical character, it's a HCPT code. If you have a CPT that ends with the F or the T, volume 2, volume 3, so on and so forth. And of course, the ICD is the 3 digits with the 2 decimal points. Has anybody ever heard of CPT codes? Essentially kind of the same process, but it's for dental. It's current dental terminology. So keep that in mind. What about ABC codes? Those are holistic medicine. There's a code set for essentially everything out there, but the skills that you're learning and applying these codes and assigning these codes, you'll be able to actually cross-function and pick up the other classification systems easily. So just keep that in mind. Don't let it limit you and think, I can only do this, you know. When you find that niche, what you enjoy doing out there in industry, you know, run with it. We had a coder that's been coding for 25 years in the program that codes for an orthopedic surgeon. In this entire book, she's only used 2 sections, hands and feet. That is it. That is it. Because she's specialty specific. When you go out there, you'll all see once we start getting into the coding, you know that song from Lady Gaga, Poker Face? If you hear me chuckling, it's because I have coder face going off in my head. So if you hear me chuckling in the classroom, that's what it is, because it just happens to me every year. It's like, when you start to really get into the procedural coding, you really have to put on that detective hat. You really have to use your tools in your toolbox. Research. It's almost, because you're not performing these procedures, so you have to understand the procedure that's being performed. So you can't be afraid to go out there and watch WebMD or watch some of these resources that are out there for you to actually gain a little bit more information about what's being done. Sometimes you gotta really understand it to know this is what they're doing. And some of you may really enjoy that, some of you might not stand it. But you gotta, you know, kind of get through it, because typically out there in industry, HIM professionals supervise coding professionals. So whether you're a coder or you're an HIM, you're in the same boat. So it's interesting though. It is interesting. I think I've kind of gotten through this whole first PowerPoint without even looking at it. And I apologize, I said for the CPT, they're category 1, 2, and 3. I think I said volume. Yes, they're categories, so I apologize on that one. But I think that we've kind of gotten through this first one. Of course, your medical record documentation, the documentation has to be complete in order to have correct medical coding. CPT codes are based on operative notes. They're based on discharge summaries, history and physical. It's kind of abstracting from a number of different documents from the patient's medical record in order to apply these codes appropriately and specifically. Has anyone ever heard of a super bill?
Does it list everything?
It does, and I'm sure you've all seen one of the providers when you go in and they give you a piece of paper and they check off like a specific code, and then they have you bring it up to that code. That's CPT code. Typically, a lot of healthcare organizations know what services they provide.